Good morning, students. So today our topic is IVF issues. Myself, Dr. Manisha Choudhary. I'm professor in the Department of Reproductive Medicine, and I'll try to cover the different issues related with the IVF, especially when there is need of IVF, when we have to refer the patient for the IVF, where to refer and how to refer. So to start with the definition of infertility, according to ASRM 2008, failure to achieve pregnancy after 12 months or more of regular unprotected intercourse is termed as infertility. But earlier evaluation and treatment is justified based on the medical history, physical findings. Suppose the patient is of advanced age, or if he or she is already having a diagnosed case of infertility like azoospermia. So in these cases, the investigation is warranted after 6 months or as soon as the patient came to you. 1 in 7 couples, they experience a problem with the conception in their reproductive lifetime. So roughly 15% of couples of reproductive age, they face some problem in getting conception. Out of them, 40 to 50% are associated with the female factors, and the same 40 to 50% with the male factor. And in female factor, the most important cause is the tubal and the pelvic factors and ovulatory dysfunctions. Unexplained and unusual factors or idiopathic factors, they cover 10 to 20% of infertility. Grossly, we can classify the infertility as a single defect in one partner, multiple defects in one or both partners, or as unexplained. In single defect, if it is correctable, we try to correct it, but only half of the patients, they usually respond to the conventional treatment, and especially if the duration of infertility is prolonged, while rest, they require some kind of ART help. In cases of multiple defects in one or both partners, we usually have to refer these patients early to the ART. And in unexplained infertility, especially if it is more than of 7 years, the need of ART increases. In females, during evaluation, we have to cover the tubal, we have to look for the tubal status. Then there are some tests to confirm the ovulation, and there are some tests to confirm the ovarian reserve of the female, accordingly to take the decision of ART. I am not going in details. The semen analysis is the one and the only very important investigation in cases of male, and endocrine and genetic evaluation is required in selected cases, especially the severely compromised male factors. Now come to the ART, assisted reproductive techniques. ART includes all fertility treatment in which both eggs and sperms are manipulated. By definition, IUI should not be included in the ART, but because of the extracorporeal male gamete manipulation and the super ovulation of the female partners, the majority of clinics, they consider IUI as one of the technique of ART. Now the steps of IVF are: first we have to select the suitable cases for the ART, then we stimulate and monitor the cycles very strictly. The ultrasound guided oocyte retrieval, the fertilization and the cleavage, early cleavage takes place in the laboratory, and again these embryos are transferred either on day 3 or 5 of the cycles. And then comes the role of luteal phase hormonal support. There are some myths about IVF in people, like it is limited to the young population, or it is successful in all cases or in none cases. It requires admission. So there are lots of myths. It results in multiple pregnancy in all cases. So we will try to clear out these myths during our discussion. So the important issues are when to refer, where to refer, and how to refer these patients for the IVF. When to refer? Some important indications. The group 1 includes the tubal factor. In cases of irreversible tubal damage, either infective or it could be tubercular. Post-operative, like ectopic and sterilization patients, and endometriosis. So the success depends on the type of the tubal damage, whether it is mild, moderate or severe, and whether it is unilateral or bilateral. But in general, the post-operative and the endometriosis, they have a better prognosis than the tubercular factor of tubercular cause of tubal blockade. Now, infective tubal damage, the pre-IVF hysteroscopic, rather hysterolaparoscopic evaluation is essential to find out the cause of tubal damage, whether it is infective or tubercular, and if there are any synechias, intrauterine synechias, then need some operative measures to correct them. Then followed by the prolonged antibiotic treatment of both the partners. Remember, it should always cover both the male and the female partners. Communicating hydrosalpinxis may held responsible for the implantation failure, as the fluid in it is embryotoxic. So either salpingectomy or clipping of hydrosalpinx is done in the same setting. So the consensus is now in favor of pre-IVF salpingectomy or clipping or diathermy of the corneal end of the distended tubes to prevent the embryotoxic effects of this fluid. In cases of genital tuberculosis, same, the hysterolaparoscopy is the modality, is the diagnostic modality of choice, and if we find the tubercular lesions, definitely we have to cover it with the ATT, but mid-cycle color Doppler evaluation of the endometrial blood flow, endometrial quality is very important to predict the success rate in these patients. Same, the clipping is required if it is if the hydrosalpinx is there. But usually, as I already told, the results are compromised in the tubercular patients. What is the role of tubal surgery in this era of ART? Surgical outcomes are inversely related to the severity of the disease, and results of microsurgeries are good in the milder forms of either the distal tube disease like fimbrial phimosis or fimbrial block. The live birth rate goes up to 50%, or if there is mild corneal block, we can use cannulation to open this block. But in severe diseases, the success rate are very low, 10 to 35%, and even if the patient conceives, the risk of ectopic pregnancy is very high. While the live birth rate of IVF is it goes up to 35 to 40%. So decision, it depends whether we have to go for the microsurgery or the ART. It depends on the age, the duration, the severity, the cause of tubal damage, as well as the affordability of the patient. Now, group 2 includes the anovulatory patients, and the major part of this group is the PCOS cases, which is responsible for 75% of anovulatory infertility, the failure, and now when we have to take the decision of IVF, when there is failure of medical or surgical management for a reasonable time, say about 6 to 8 months, with the induction with the clomiphene citrate with or without gonadotrophins, use of some adjuncts like insulin sensitizing agents or mild dose of steroids or thyroid or weight loss. So after a reasonable trial of 6 to 8 months, if the patient is unable to conceive, then it's better to switch over to IVF, especially considering the age of the patient. IVF in cases of premature ovarian insufficiency or poor ovarian reserve, usually the IVF goes with the egg donation, and the ICMR guidelines suggest that the donor should remain anonymous. After donor oocyte, the success rate are very good. It goes up to the 50%, and then comes the group of hypogonadotrophic hypogonadism. Primary amenorrhea due to deficiency of the GnRH secretions with the low levels of FSH, LH is characteristic of hypogonadotrophic hypogonadism, and because of the hormonal deficiency, the uterus and ovaries are smaller in size with the thin endometrium. So first we have to give ART to correct this hypoplasty for 3 to 6 months, followed by the induction. But because of the prolonged use of the HRT, these patients, they usually need higher doses of gonadotrophins for stimulations, and they usually develop the multifollicular growth. So they usually end up with the IVF. Now, group 3 includes endometriosis patients. IVF as a primary treatment in minimal or mild endometriosis is doubtful, but results of IVF in the early endometriosis are definitely better compared to the medical, surgical or expectant management of stage 1 and 2 endometriosis. In moderate to severe endometriosis, IVF combined with the surgical manipulation like ablations or fulgurations or cystectomies or the medical treatment before IVF, they definitely gives a better outcome and a better result. Group 4 includes male factor. Thank you.